So I just wanted to give you guys a very quick video on lung cancer. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at lung cancer. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notification of such amazing content every time I post. Drop a like, drop a comment, show some support to Zambia and beyond. Grab your piece of paper and your pen and let's go. Here's a warm-up question, which is a single best answer. A patient with small cell carcinoma of the lung has been complaining of weakness in his leg muscles, weight gain, and darkening of his skin. What is the most likely diagnosis? Adrenocortical tumor, radiation side effects, ectopic adrenocorticotrophic hormone secretion, diabetes mellitus, or side effects of the steroids. You may pause the video at this moment. Write down your answer. I will give you the answer at the end of the lecture. So remember that lung cancer is actually the most common cause of cancer mortality and cancer death worldwide. And generally, it's also one of the tumors that actually is responsible for metastatic spread to the bones. Remember that most of the metastatic tumors that are going to be happening in the lungs are far much more common than the primary tumors that we see in the lungs. And these are going to be coming from the breast, the thyroid, the stomach, the colon, the prostate, as well as the ovaries. And whenever you have this metastasis from elsewhere in the body, and then you have it spread into the lungs, then you get this characteristic appearance, which is what we refer to as cannonball nodules on the imaging. So this is a very characteristic x-ray that you must actually have an idea of, because it's very common on your OSCE stations. Then 90 to 95% of the primary tumors in the lungs are going to be arising from malignant epithelial tumors, so we collectively refer to these as bronchogenic carcinomas. But you also have the bulk majority of other tumors, that's a 5 to 10%, which are pretty much going to be your bronchial carcinoids, mesenchymal tumors like lymphomas, sarcomas, leiomyomas, lipomas, fibromas, leiomyosarcomas, and bronchial hematomas. And this one is actually not even a malignant tumor. It's actually a benign tumor with just this abnormal differentiation of the bronchial tissues. Remember that the cancers are far much more common in older men than they are in women, so the age range is usually between the age of 65 to 75. This is only explained because men usually tend to work jobs that may put them at risk of developing lung cancer in the future. They tend to have certain behaviors that may put them at risk of developing lung cancer in the future, such as smoking. But of course, now we do have women that are even smoking more than men. So remember that the ratio of men to women is about 2 to 1. What are some of the causes and risk factors that are associated? Like I say, it's cigarette smoking. So cigarettes that contain, remember that the cigarettes are going to be containing at least 55 carcinogens. Remember, a carcinogen is a cancer-causing substance. So it's going to be containing at least 55 carcinogens that are going to be putting them at risk of lung cancer. And remember that the risk is actually increased to 20-fold in people that actually smoke more than 40 cigarettes per day. There is also an exposure to radon from a radioactive decay of uranium in underground uranium mines. This could be occupational related. Like I said, it's most likely the male gender, or indoors in the basement as a colorless, odorless gas. Then exposure to other carcinogens such as asbestos. Most of the previous homes that were built very, very long ago, the roofing and the ceiling actually had a lot of asbestos. This actually predisposes individuals to developing lung cancer whenever it's inhaled. Also, polycyclic aromatic hydrocarbons. These are going to be containing mutagens, and they're going to be present in cigarette smoke, as well as arsenic. You also have nickel, copper, and chromium, as well as silica, mustard gas, which was used in World War I. Then what are the pathological features of bronchogenic carcinomas? Remember that we're going to be dividing them or classifying them. There's a classical classification or a classic division of the cancers, and generally the cancers are going to be arise. They can also classify them based on the tissues that they're arising from. So we divide them into two main groups when we're looking at the classic division of the lung carcinoma. We have what we call the small cell carcinomas, which are also referred to as an oat cell, which are representing 15%. These ones are very dangerous. Reason being, most of the time they're diagnosed at a late stage and where they've already metastasized. So most of the times even surgical therapy cannot really help the person because the tumor is already spread. Then you have the non-small cell carcinomas, which account for 85% of the tumors, which are the adenocarcinomas, the squamous cell carcinomas, the large cell carcinoma, and the carcinoid tumors. So remember that these are going to be originating from the bronchial epithelium. So you're going to have four main histological types. So you're going to have an adenocarcinoma, which is going to include a bronchoalveolar carcinoma, accounting for about 30 to 35%. You're going to have a squamous cell carcinoma, which is 25 to 30%. A small cell, which is also referred to as an oat cell carcinoma, which is 15 to 25%, and a large cell carcinoma, which is about 10 to 15%. Other types of tumors include mixed cell tumors, which are going to be comprising of squamous as well as small cell, or sometimes even squamous cells, and adenocarcinomas, which are accounting for 5 to 10%. You may also have pleomorphic carcinomas, which are mixed carcinomas and sarcomatoid patterns, and this is accounting for about 0.5%. Remember that differentiating between the small cell carcinoma as well as the non-small cell carcinoma, that's predominantly the adenocarcinomas, your squamous cell carcinomas, and even your large cell carcinomas, is very, very important. Remember that small cell carcinoma is very responsive, at least initially, to chemotherapy. The reason why it's deadly is because it gets detected very, very late. So most of the times it has already spread to the other parts of the body. Then all lung neoplasms are actually very aggressive, and they're very invasive and widely spread. They can spread to the liver, they can spread to the adrenals, they can spread to the brain, and like I said in the previous slide, this is one of the tumors that can actually spread to the bone. They also do produce certain bioactive hormones and other products that can give you these characteristic symptoms that are going to be part of a syndrome which we refer to as a paraneoplastic syndrome. So let's begin with our adenocarcinoma. Remember, adeno means gland, carcinoma means it's arising from epithelial tissue. So you're going to be having this tumor that's arising from the glands, or mucin producing glands, and it's very common in women than it is in men. It develops in the periphery of the lungs, and it's the commonest lung cancer in non-smokers. Okay, so this one is the commonest lung cancer in non-smokers, and some adenocarcinomas are actually going to be arising from the areas in the pulmonary fibrosis or a scar. So this is in the background of an old infarct, or sometimes even with asbestosis, or even with a healed TB scar, and this is actually referred to as a scar cancer. These are going to be located peripherally, like I already said, and there is a chance of distant organ metastasis in 50% of the cases, especially to the brain. It carries a poor prognosis and has a 5-year survival rate of about 10 to 12%. Then we do have the squamous cell carcinoma. Now these ones are going to be arising from squamous cells, epithelial cells, and when you look at them under the microscope, they're going to have this keratin pearls or intercellular bridges, which are pretty much the desmosomal connections between the squamous cells, which we see on histology. This is common in males than it is in females, so it means this is also going to be associated with cigarette smoking. Now this one tends to arise centrally in the major or the segmental bronchi, and then spreads to the hilar lymph nodes in about 70 to 90% of the cases, or the distant mets in 50 to 60%, or vice versa. Now these type of tumors can actually produce parathyroid hormone related peptide, which can lead to hypercalcemia. Remember what I told you about the paraneoplastic syndrome, and often it also carries a poor prognosis. That's a 5-year survival rate of about 5 to 8%. Another thing is that remember that whenever you're inhaling and exhaling with your lungs, you're using more or less the upper regions of the lungs. So it's not so common that we actually see these cancers in the upper regions of the lungs, because that's where most of the air, quote unquote, is going to be going. Then we have our small cell carcinoma, which is going to be having our poorly differentiated small cells arising from the neuroendocrine, which are known as the Kaczynski's cells. This is actually quite aggressive, and it metastasizes quite early. So this one is strongly associated with cigarette smoking, and it's also centrally located, and it's commonly associated with paraneoplastic syndromes, where you can produce ADH, you can produce ACTH, which is adrenocorticotrophic hormone, or it can actually result in a syndrome that's known as Eaton-Lambert syndrome. then you do have a poor prognosis. In 5-year survival rate is about 5 to 8%, which is actually very, very low. Then we have our large cell carcinoma, which is pretty much an anaplastic type of tumor, so it's rather undifferentiated. It also occurs in smokers. It doesn't have any keratin pearls or any intercellular bridges. There are no glands, there's no mucin. It can either be centrally located or peripherally located, and this one tends to metastasize very quickly and very widely, and also carries a poor prognosis. Then we have our bronchoalveolar carcinoma, which is these columnar cells that are going to be growing along a pre-existing bronchiole and alveoli. So these are going to be giving rise to what we refer to as the Clara cells. And these are not related to smoking, and it's going to be found peripherally. And then, of course, this may present with a pneumonia-like consolidation on our imaging. But these ones, unlike the other cancers we talked about, this has an excellent prognosis. Then we have our carcinoid tumor, which is pretty much a tumor of well-differentiated neuroendocrine cells. And when you stain it with chromogranin, it's going to be positive, and it's not related with any smoking. It's either found centrally or peripherally, and this one tends to form these polyp-like masses in the bronchi, and this is actually a low-grade malignancy, so it rarely can also cause carcinoid syndrome. Now, what are some of the clinical features of someone who actually comes in with a lung tumor? So the clinical presentation may actually be variable. It may either be producing symptoms in the pulmonary system, so we call those as local symptoms, which could be features of obstruction, respiratory symptoms. Or it could be features of metastasis, where it spreads to another organ. For example, if it spreads to the liver and this person goes into liver failure. If it spreads to other parts of the bone, for example, other parts of the body, for example, the bone, leading to those pathological fractures. So this depends on the area where it has actually metastasized. Then you can also have ectopic hormone secretions, which could be part of paraneoplastic syndromes. Remember that these are going to be a group of rare disorders that actually are triggered by an immune abnormal response to the cancerous cells, to a neoplasm. So the body actually produces these antibodies that can cause this abnormal response in certain types of cancers, and sometimes even these cancers can start producing certain types of chemicals, certain types of hormones that they're not supposed to be producing, giving rise to these characteristic symptoms that we often see. And about 10 to 15% of lung tumors are actually detected by chance, so you get a coin-shaped lesion on the x-ray. So as you can see on this x-ray, this is an x-ray that's done on an individual. You can see this round thing in the corner. Let me just zoom it for you over there so you can have a good idea and actually look at it very well. So you can see this is a coin lesion. So this is very, very characteristic of our lung tumors. And of course, for the benign lesion, for example, if you see it in a young person, remember this could be a granuloma, it could be as a result of TB or histoplasma, it could be a bronchial hematoma, and these are often calcified. Now, what are some of these local symptoms that we get? So these also depend on the location of the tumor. So if the tumor is inside the bronchiole, there may be some coughing. There may be some coughing out of blood, which is hemoptysis. You may have stridor. You may have wheezing. You may have dyspnea. You may have non-resolving pneumonias, which may predominantly be there. This is if the tumor is found within the bronchioles. Then, of course, or the bronchus. Then, of course, you may have pleuritic chest pains if it's in the peripheries, close to the pleura, and sometimes symptoms may be as a result of local tumor invasion or even obstruction. For example, if it's actually affecting the recurrent laryngeal nerve, you may have a recurrent laryngeal nerve palsy, which can actually cause hoarseness of the voice. If it's affecting the phrenic nerve, this may actually cause paralysis of the diaphragm. So actually, when you take an x-ray, you see that the diaphragm is elevated. Then you may also get dysphagia with esophageal obstruction. You may get superior vena cava obstruction, which can present with edema. Now, this edema is very characteristic because it tends to affect the face and the upper limbs. Then you may also have what is known as a Pancoast syndrome. So this exists when you have this apical mass in the lungs that is going to be infiltrating the spinal nerves, predominantly our C8 to T1, and this can actually result in shoulder pain and cervical sympathetic nerve involvement, which can actually result in what we refer to as Horner syndrome, which has a triad of three things. Anhidrosis, meaning the absence of sweating on one side of the face, ptosis, which is drooping of the eyelid, as well as meiosis on the affected side, which is of course constriction of the pupil. Then you may also have pericardial or even pleural effusions. Bronchial obstructions can actually lead to atelectasis. They can cause pneumonias. They can result in lung abscesses. Then sometimes you may have this ectopic hormone secretion, like I said, the paraneoplastic syndromes. We don't really know what really causes this, but one suggested mechanism is due to the abnormal response to the immune system. Another could be due to production of certain hormones. So remember, this occurs in about 10 to 15% of the bronchogenic carcinomas, and this actually manifests as related to ectopic hormone secretion by the tumors. So remember, the manifestations for this can actually be either systemic or they can be related to different systems. So generally, they're going to be having systemic symptoms of anorexia, loss of appetite, cachexia, which is extreme weight loss. Then you may also have fever. You may also have this fever in 30% of the cases. Then another 1/3 of the patients actually may present with endocrine manifestations such as hypercalcemia or hypocalcemia. This is either as a result of production of parathyroid hormone. This can result in hypercalcemia, or production of calcitonin, which can result in hypocalcemia. Sometimes you can produce a lot of ACTH, adrenocorticotrophic hormone, which then can present with Cushing syndrome, where this person can have obesity, they can have changes in their skin, thinning of the skin, abdominal striae, and all those other features that we see in Cushing syndrome. They may also have gynecomastia from ectopic secretion of gonadotrophins, and sometimes they may have inappropriate release of ADH. That's the SIADH, syndrome of inappropriate ADH secretion, where they actually have sodium and water retention. Now, additionally, patients actually may present with other features such as clubbing, migratory thrombophlebitis, cerebellar degeneration, neuropathies, and even some myopathies such as Eaton-Lambert myasthenic syndrome. Now, remember that in this Eaton-Lambert myasthenic syndrome, there's actually some weakness of the muscle. Now, what's happening in this weakness of the muscle is that there is this autoimmune process that is going on where you're making these antibodies. These autoantibodies are actually going to be attacking what we call the presynaptic voltage-gated calcium channels. Now, if they attack this presynaptic gated voltage calcium channel, this is going to impair the release of acetylcholine. And once the release of acetylcholine is impaired, this is going to be leading to problems with the neuromuscular junction, and is going to result in proximal muscle weakness. It's going to result in depressed tendon reflexes. You may also have myasthenia gravis, where you have these autoantibodies that are attacking the nicotinic acetylcholine receptors on the postsynaptic membranes. Remember, myasthenia, Eaton myasthenic type of syndrome is with the presynaptic neuron, and then myasthenia gravis is with the postsynaptic neuron. Then this are both going to result in this muscle weakness. They may also have anemia as well as thrombocytopenic purpura. Now, what's the diagnosis? So remember, we want to screen all patients. For all men that are above the age of 40 and those that are smoking more than 40 cigarettes per day, we should make sure that at least you get a chest x-ray. Cytology can also be done, and this can help detect the malignant cells in about 50% of the cases. It's actually 50% sensitive. Then, of course, when you do our x-ray, you may see a solitary pulmonary nodule, a coin-shaped lesion, which is about 2 to 5 centimeters, and about 35% of the cases, these are due to the bronchogenic carcinomas. So as you can see, like I showed you the coin-shaped lesion earlier on. So we should actually compare this x-ray that you take to any other past x-rays that this person has taken to ensure that this is a benign entity. It's not enlarging. There are no changes that are happening that may suggest that this is a carcinoma that would warrant this person actually getting a biopsy. They may sometimes have effusions. They may have lobar collapse. They may have mediastinal or even hilar lymphadenopathy that may be seen. Other investigations include baseline investigations such as a full blood count, UNEs, LFTs, as well as the LDH. Remember, LDH tends to be risen, especially in small cell lung carcinomas because of the tissue necrosis. Calcium also may be increased in squamous cell carcinomas, or generally may be reduced. We can order for certain tumor markers. We can also get a lung biopsy as well as a lymph node biopsy, especially from enlarged lymph nodes or supraclavicular lymph nodes. This is often to detect any metastasis. A bronchoscopy with a biopsy or a lavage, if the CT scan actually shows that the mass is accessible, can be done, or the lymph nodes are accessible. This can be done. Thoracocentesis, and then we can collect the fluids for cytology. If they have a pleural effusion, you can sometimes get a pleural biopsy. Even a mediastinoscopy can be done for these patients. Now, how do you manage these patients? Remember that the prevention of lung cancer is to actually cessation of smoking, remove the risk factors. So for the non-small cell carcinomas, surgical excision is almost curative, actually is curative for these patients. And if you actually remove the ipsilateral lymph nodes that are involved, but without local or distant spread or contralateral lymph node involvement, surgery can actually be curative for these patients. Then if it's actually spread to the other parts of the thorax, then of course radiotherapy is going to be done, but this is only palliative. Then with a Pancoast tumor, which is a tumor in the lung apices, we can actually perform radiotherapy or chemotherapy. Then with the extrathoracic disease, generally it's just palliative care. So analgesics, radiotherapy, dexamethasone, obliteration of the pleural cavity. This is just basically for symptomatic management. For the small cell carcinomas, remember by the time the diagnosis is actually made, 95% of the tumor has already spread. So most of these, even though surgery can be curative, surgery is not done in most of these cases because the tumor has already spread. It's actually quite responsive to chemotherapy plus or minus radiotherapy. For the bronchial adenomas and the carcinoids, this often just needs surgical resection. Now coming back to our warm-up question, which is a single best answer. A patient with a small cell carcinoma of the lung has been complaining of weakness in his leg muscles, weight gain, and darkening of the skin. What is the most likely diagnosis? A. Adrenocortical tumor. B. Radiation side effects. C. Ectopic ACTH secretion. D. Diabetes mellitus. E. Side effects of steroids. So remember, this person has a small cell carcinoma, so most obviously they have a paraneoplastic syndrome and they're producing ACTH, which is causing these features: the proximal muscle weakness, which is due to the wasting of the proximal muscles, the weight gain, of course the truncal obesity, the darkening of the skin, because ACTH has a similar structure to the melanocyte stimulating hormone, and it actually can stimulate melanocytes, and this can actually cause darkening of the skin. So most likely this is caused by ectopic adrenocorticotrophic hormone secretion, ACTH. I really hope you enjoyed this video on lung cancer. If you did enjoy, consider subscribing to the channel, hit the bell notification icon so that you never miss any of such content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye bye.